Hey everybody, I'm Jess Lupini, and this is the Words Don't Fit the Picture, the show where we untangle the strange and fascinating relationship between gender, voice, and identity. This episode is part 2 of my conversation with Dr. James Thomas, a laryngologist who specializes in pitch-altering vocal surgery. When we last left off, we were talking about some of the different options available to people looking to surgically raise their vocal pitch. That includes the older cricothyroid approximation, or CTA, the newer FemLar, or feminization laryngoplasty technique that Dr. Thomas developed, vocal cord webbing, and other techniques like using lasers to help tune up patients. Here's part 2 of our conversation.
Thanks. All right, we're back on.
Okay, great.
You ask your question and I'll continue.
So we haven't really talked about webbing too much. So could you tell me a little bit about what webbing is, how popular it is, how effective it is compared to the other ones we've discussed?
Yeah, I think of the term webbing in general is operating through the mouth while the patient's asleep and sewing the front half of the vocal cords together so that it can't vibrate, and the back half of the vocal cords remain to vibrate. And there's some variations on that. Different surgeons use different kinds of sutures. Different surgeons put the sutures different ways. And that is clearly the most popular surgery. It has I would say relatively low risk if the surgeon has good judgment. If the surgeon webs 90% of the vocal cords, then the person's going to have almost no volume, and I've seen that. But I think that's a judgment.
Yeah.
So if the surgeon's careful, does enough of them, then I think they can accomplish something.
Right. So really, it seems like the three approaches that exist for the major surgeries for this are the cricothyroid approximation was going in and sewing together this joint to do the work of this muscle that wasn't really the right muscle for the job. And then we've got webbing that's affecting the actual vocal cords themselves, but isn't changing the resonance chambers at all. And then the feminization laryngoplasty, where we're actually going in and changing the shape of the resonance chambers as well as the vocal cords. Is that right?
Yeah, I like to think of it as those three, and I think of it as 4 because you can use the laser and just debulk the vocal cords. But alone, that doesn't tend to give much pitch raise.
Gotcha.
But it's an incredibly valuable procedure if a person has already had a webbing or a feminization laryngoplasty and the vocal cords are short, and now you debulk them, it can do quite a bit. So almost it's 4 different surgeries: laser, some sort of debulking, and the 3 you mentioned.
Gotcha. And so for most patients, what do you recommend as being the result that's going to achieve the greatest likelihood of success for them?
Well, assuming a patient comes to me and we talk over that they're willing to take on risk, or they want to take on the risk in order to never sound masculine, then they've jumped the hurdle from speech therapy to some type of surgery. And then I would say, don't ever consider CTA. It has too many complications. It fixes your voice. It reduces your range. Don't do that. And then I think the real 2 choices are webbing or feminization laryngoplasty. Feminization laryngoplasty does, I think, more, but it's a bigger surgery with more complications and very few people do it. Webbing's very common, easier, low complication rate. If it fails, you could do other things. And most people who actually publish on it typically say you need to do some voice therapy. And I have to say, I've never heard a series of like 100 patients who've had webbing and 100 patients who've had feminization laryngoplasty to do a real formal scientific study. So I have to say there's things I don't know. I don't have a perfect comparison of the two.
Right.
And people come to me because they know I do the laryngoplasty, so I don't do a lot of webbing because I've established myself, and I really only do webbing on request, so I don't have a huge track record in it.
After surgery, what is the recovery like before someone's voice is back to 100% with their new voice?
Well, I think it's different between webbing and feminization.
Mm-hmm.
So I think webbing has a relatively quicker recovery because not much is changing structurally, and the swelling goes down quicker. I think because I change more of the structure, there's both more swelling, so early on the voice is quite often worse, and then it takes longer for the person to adapt to it. So the feedback I would give is from patients who come back to me over many years. I think most patients say it takes about 9 months after feminization laryngoplasty until the voice is like completely stable. That's the early surgical swelling, and that's the retraining that goes on in your brain as you keep modifying internally what you're doing with these new vocal cords.
Mm-hmm.
And then I tell patients that it takes about probably 2 months for the swelling to go away. So I tell people to rest their voice for 2 weeks, try not to tug on any of the stitches by talking. And when they start talking, their voice will probably be almost as deep as it was before surgery, and then the swelling goes down and the voice gets smoother and clearer. And I start to judge my result by about 2 months after the surgery.
Gotcha.
And I've had 2 or 3 people who come in 2 weeks later and sound great, and they didn't swell. And I don't know, I think that's their own personal characteristic. It's not anything I did with the surgery. There's some people who don't swell much, and a few of them sound really great really early, and that's unusual. But 2 months of getting through a pretty rough voice, and then another 7 months of gradually getting used to it.
So one thing that I just wanted to come back to for a second around the concept of range is, like, obviously all of us have like the lowest note we can hit at the bottom of our range and then the highest note we can hit at the top of our range. When
Yes.
we're talking about like, oh, we're moving up by this many notes on the piano, is that the bottom and the top are moving together, or do those tend to move independently of each other?
I like to think of it as 3 pitches. So you and I are conversing in our relaxed voices, so our comfortable speaking pitch.
Yep.
And the comfortable speaking pitch is not in the middle. It's down typically towards the low end of our range.
Mm-hmm.
And then we have the 2 notes you mentioned, the lowest and the highest. And when I do the femoral surgery, to me, my experience says the upper pitch doesn't change. It stays the same. The lowest pitch comes up on average about 8 to 10 notes, depending on where you start. And the comfortable speaking pitch comes up about 6 or 7 notes. So it narrows the range from the bottom up, and it shifts the comfortable pitch up, the pitch that you speak at without thinking.
Right.
Yeah, so it does narrow the range. The exception is there's an all too common complication from a related procedure called a trach shave, which is getting rid of the Adam's apple. And some surgeons who do that may not be aware of where the vocal cords attach on the inside, and sometimes they loosen them, and that drops the pitch. And if I go in and repair a trach shave, a lot of times I can restore the upper pitch. That is, I just told you I don't change the upper pitch, but if the upper pitch has artificially been dropped, you can often bring it back up to where it used to be.
Trach shaves are done quite commonly. Like, it's a very, very common surgery for a lot of trans women, especially. How risky do you consider those to be?
Well, I don't have any numbers. I don't know the denominator. I don't know how many people get them. I see lots of complications, but people come to me when they've had a complication.
Of course.
So I don't have a good assessment. I can just say to all the plastic surgeons out there in the world, leave at least 1 centimeter of thyroid cartilage in general, and you'll keep the vocal cords attached. So that means when you're doing a trach shave, you want the person to look good, but you may have to leave a bump there or risk detaching their vocal cords.
Right.
It's a judgment of how if you take away every bump that's there, you're probably going to start having complications with some people losing their upper range.
Got it. So if somebody's considering getting a trach shave, do you have any advice for them to avoid ending up in a situation where they could end up having their voice partially compromised?
I don't have any perfect advice there. I mean, I give my patients some advice. That is, if you're going to have the feminization, don't get the trach shave, because now you're having 2 surgeries and you're paying for 2 on the same spot. And if you're going to have the feminization laryngoplasty, we're going to get rid of it anyway, so save yourself risk and money. But apart from that, no, I don't know how to judge a surgeon without being there myself.
The message I'm getting from a lot of this, including talking about the pitch surgeries and really everything in general, is that we need more research and better clinical studies.
Yeah, I think, and that's the next, I think as more people get interested in doing it, doing webbing, doing trach shaves, doing maybe the laryngoplasty, you will get more studies, you get more ideas, and maybe a new idea will come along that's better than any we've talked about so far. So
that kind of makes me think a little bit about something I noticed on your website, which it's really interesting to hear that you started that quite a long time ago, like more around the dawn of the internet as we know it. But something that really jumped out to me when reading your website and some of the content you've written is the way you talk about these procedures. Like, you have a lot of notes, personal notes, anecdotes, and you talk as well about how you've changed your recommendations over time as you've performed more of these surgeries, and as the field has evolved in general, especially in respect to talking about revisions, times when revisions were necessary, or even where you feel like certain mistakes were made. And this feels really different to me from a lot of what you see on surgeons' websites, where it's very sanitized, careful, focusing on the positives. Can you tell me a little bit about that approach? Because it does jump out to me as unique.
Well, I think that's a little heads up. If I needed orthopedic surgery and I looked at a website and they have only great results, I'd probably look elsewhere. I think that all of these voice surgeries and all surgery have complications. I can't think of a single surgery that doesn't have the potential for a complication. And really, if I only had good results, I wouldn't have to talk to anybody. I'd just do the surgery, So if the surgery site website, or if even a physician website only shows positives, and you go to the appointment and they only talk about positives, then you're going to have a problem, or there's more likely to be a problem there in that case, I think.
Right.
So that's probably what informs my approach. I mean, what do I lose by telling someone they could have a complication? And now they're informed. If we don't have it, they're happy. If they have it, maybe they're not happy, but we can move on from there.
That is cool to hear. On one hand, I think it's really great that there's options for people to access newer, potentially life-changing procedures, like thinking about that first patient who you were able to do the feminization laryngoplasty to. That's so incredibly cool that this person was able to be one of the first people to get this surgery. But then on the other hand, performing these outside of the context of clinical studies and trials means we have less data on the long-term effects, success rate, complications, etc. So how do you balance ensuring that these procedures are accessible while also making sure that we're still moving towards getting the data that we need to understand what's going on better and make it more accessible?
Yeah, I think you have to rely a little bit on the various physicians, and some are going to go more in depth and study what they've done and change what they do as they go along. And others are in your upsell category where they do a lot and we have no idea what their outcomes are, unless you maybe run into or meet other patients. I think the internet keeps evolving. I think now one of the big sources apparently is Reddit, which I have. I'm aware of it, but I've not gone on and looked at any transgender voice stuff on it. But that seems to be a patient-oriented discussion area, and that's not really a terrible way. I think you could go, say, to a trans meeting and meet the surgeons, meet a variety of people, and then you could try to suss out from other patients how they've done, and you'll hear both good and bad, and then you put that together and you make, hopefully, an educated decision about what you should do and who you should see.
So these communities that we're talking about are obviously great places for people to discuss their experience, sometimes positive, sometimes negative, and pros and cons of various procedures and surgeons and clinics. One thing that is often talked about as a negative in the context of cosmetic surgery is the need to do revisions, where usually it's talked about in the context of, okay, I got this procedure, whatever it was, I was dissatisfied with it, and so I had to go back and get more work done until they were able to get it right. Whereas I would have preferred them to just get it right the first time. When you talk about revisions, and when I've seen patients talk about getting revisions from you, you use the word like tuning up, the phrase, come back in and get tuned up. And it seems like revisions are talked about in a different way. Can you speak to that a little bit?
Yeah, I think even today, I went back and looked at my spreadsheet. I mean, this is a procedure I obviously have a lot of fascination with, so I keep pretty detailed records on it. I know that I've done 369 patients, and I know how many I've followed up with. But I can look back on that spreadsheet and also see that, the first 50 I did, that I revised maybe half of them, where I would go back in and do a second feminization laryngoplasty. I would open it back up. And maybe that's because it was new, and maybe it's because I didn't have another tool at the time. And one of my discoveries, which is in, I think, the video that I give as a general lecture, is that a woman came back to me and her voice was rough like this, and I could look in there and see one vocal cord was looser than the other. And I had just bought this new toy, a laser. I told you my profession's filled with nice toys. So I bought this nice $90,000 laser. And I thought, well, I could use this here. And I used the laser to make a little burn, and it tightened that up, and her voice cleared up. So I learn as I go. And I think that was much easier, much less risky than a revision. And so I often use the laser to tune up. So the reason I use the tune-up is the laser, and there's two, I can adjust side to side, get the vocal cords in tune. That seems like a tune-up. I can thin them out and make them a little thinner, and they vibrate a little higher pitch. So that seems like a tune-up, let's say, as opposed to a revision where I open up the neck, take it all apart a second time, work through scar tissue, and try to do something big again.
Gotcha. So, but you are, especially with the feminization laryngoplasty, like you're, is it safe to say you're shooting for just needing to go in there one time, get it right the first time?
Yeah, I mean, that's what I would like. That's what everybody would like. And I must say that I haven't gone from lots of risk and complications to none. It's not been a even parallel path. I go and I get a bunch of good results, and then some that aren't as good, and then some that are good, and then someone who's perfect, and I think, oh, I'll keep doing that, but then the next patient isn't. And I think it's just partly there's so many variables in taking apart the voice box that it's hard for me to know every single variable.
Gotcha. So something that I notice a lot in spaces where trans people are talking about voice is often a sense of desperation, especially when it comes to the context of getting surgery. And so what I'm wondering is, as you talk about, all the cool tools and toys that you have access to and pioneering new surgeries and procedures, how do you balance that desire to experiment a little bit and innovate and improve outcomes and try new things with this uniquely vulnerable population who are coming to you very in a very vulnerable, often desperate kind of way? I can see there being situations where you might have to consider some of the ethics of the choices you're making and the things that you're doing. How do you balance that?
I have to say I've not found the people who've come to visit me to maybe entirely fit that characterization. Over the years, individuals who've come to me have said voice is either more or less important to them. And some people, I've met some people, the only thing they want to change is voice, and they don't care about any other characteristic of their body. I've met people who want to change the voice first and then do other things. I've met people who want to change everything else, and the voice they save for the last. So I haven't met really a lot of, let's say, desperate people. I've met a lot of a wide variety of how people see voice in their own individual lives. So I think part of what I do is try to cater my discussion about the role surgery plays to how it would fit in your life, you as the individual, who wants the voice changed. And I run into people who want super high voices and people who want androgynous voices or non-binary voices, and I don't know exactly what that is, but we'll have a discussion and get through it. So I just find there's a wide range of people who come to me with different requests, and then I reflect back to them on what I think I could accomplish, and if it suits them, then we move ahead, and if it doesn't, then I try to guide them some other way. So I just haven't run into desperate people. I've run into a lot of very knowledgeable people who come to me that have read a lot, and then they describe what they want, and then I describe what I can do, and then we try to match it up. I guess that's how I see it. So then if I'm trying something new, I'm happy to have the discussion with the person and say, this is new, or I've been doing a lot of it, or I've done hundreds of these and I still can't tell you what the outcome's going to be. So there's an unknown. Are you happy with the unknown?
That's good to hear. Like, I do see a lot of people, especially in online spaces, talking about their voices and the pain that they are often going through when talking about their own voices. And so it's great to hear that mostly you're having people come through your doors who know what they're talking about and have a good sense of what they want.
There's probably a built-in bias to my answer to that. I think because over the 30 years I've been doing this type of surgery, it's generally, is thought of as cosmetic surgery, so everyone had to pay for it. So I would say a lot of my patients are, let's say, well-to-do. I get a lot of tech patients, people who have enough money to pay for surgeries themselves, and I have very little of people who might be more desperate because they find it very difficult to get anything.
Right.
And insurance is changing over time, and so maybe hopefully more people will be able to access this kind of service. And as they do, I might see a different group of people than what I've been describing.
Are you starting to see more like insurance coverage for this kind of thing, or is that still pretty uncommon?
No, it's much more common. I think the evolution was WPATH getting it out of psychiatry around 2010 into a medical disorder. Then high-tech firms, Apple, Starbucks, Amazon saying, well, we'll cover these surgeries, so they would selectively start to cover them. And then Medicare started covering a lot of gender surgery, but not voice, for whatever reason they considered voice excluded. So it is becoming covered more and more. That doesn't mean there's not problems with it. I still run into insurance not wanting to pay very much for it, but more insurances are covering it, and it's been an evolution. I think pretty sure most insurance will eventually cover something. It's becoming apparent to the world. There are many more transgender individuals than anyone thought. And they didn't all just appear. They have been there all along. But they're more visible, at least in U.S. and Europe.
As I think the visibility of trans people increases, so too does some of the pushback against especially the way that medical interventions can sometimes appear. Right now, it feels like we're in a really divisive time when it comes to medical care for trans people, especially in the context of surgery and especially in America. How do you feel about the way those conversations are happening in the public sphere? And have any of them affected you personally or your practice?
Well, I mean, when I hear the political ones, like my patients in Texas or some other place, and I do treat young people, it sounds like it's moving backwards. On the other hand, when we're losing ground on what we've gained, and when I go to the WPATH meetings, which are amazing meetings in that they have not only medical caregivers, but they have patients. That's one of the few organizations that's both patient and medical caregivers. Then you get a lot of interaction between a lot of specialties and between caregivers and people who receive it. And I think that helps to discuss the hard problems. The idea is, how young should we be treating? And I listen to those because I'll have an opinion, but I'll hear a thoughtful person, and maybe it'll alter a little bit what I do the next time. I mean, I think I alluded earlier in the conversation, you could put me out of business if people would get testosterone out of their system before the teenage years, and you could solve all of these problems. But there's a lot of political will against that. That's the divisiveness you talk about. And then there's probably a little bit, medicine doesn't know for sure what. You have to do research, you have to look at groups of people, you have to compare them, and insightful people can disagree and say, I interpret that as we should be doing that, or I interpret it as we shouldn't be doing that. So,
right. So, as we sort of come towards the end of this conversation, I'm wondering if you have any advice for people who might be considering voice surgery or have thought about it, but are unsure.
Well, one common piece that I give people when they come to see me is, what's your vocal rapport? Not all of us can sing and carry a tune. And for an individual who's unable to change their voice on their own, or with voice therapy, surgery becomes a better risk-benefit, has a better risk-benefit ratio. And if you're a singer and you're perceived as feminine 100% of the time on the phone, it's kind of high risk, because if you have a complication, you're worse than you are right now. And that's the initial discussion that I have with lots of people. How good are you with your voice right now? And then weigh that against the risk. And read about them, listen to this podcast, go online, and then adjust your decision-making based on your own risk tolerance. I think there's clearly a role for surgery. The woman that I mentioned at the beginning who said, I live my life as a female, it's a pretty amazing thing to have someone just satisfied with their life who wasn't for such a long time. I guess I have a wide variety of patients from, for me, 15-year-olds up to 70-year-olds, and everyone has, even if you lump transgender, trans feminine individuals together, they've all had very different lived life experiences. And then I try to slot my role as a surgeon into their lived experience and their goals.
When you think about the most dramatic or impressive before and afters that you've heard over the course of your career, do you find that those are surgery only, voice therapy only, or a combination of the two?
I don't ask anybody to do therapy. I suggest that it's low risk, and if they want to do it, they should, but I have no requirement that a person does that, because I think inherently a trans person is the gender that they feel they are, and they don't really need education to, in general, try to be something. And I say that because when I get the anatomy right, the person never thinks about their voice. So it's clear to me you can do surgery, you can have a result where the person has their own voice and they never need any training at all. If someone doesn't get as good a result, sure, they could do the training. And I think maybe a lot of this this common belief that everyone needs to do therapy, which when I go to a medical meeting, that's the status quo. Everyone must do therapy or must do therapy before considering surgery. And I think a lot of that comes from people who've lived their lives in the gender they didn't want, and they have developed a very male voice, and now they want to live the way they feel they should have lived all along, but they have to undo a lot of training. They probably do benefit from training. So if someone's in their mid-60s and comes to me, I might more orient them towards some therapy plus the surgery if the surgery alone doesn't take care of it. But my goal is, if you get the anatomy right, they sound right. None of us who are born cis female need any education to sound female. You just do it because the anatomy matches. And I think when the surgery is right, then you don't need any therapy.
How does it feel like for you personally, being such a core part of people's gender-affirming journeys in a lot of these cases?
Well, I mean, I like doing something really well. Back to the beginning, I like being a subspecialist. I like trying something. I mean, every week that I operate on somebody, I also see people back who didn't have a perfect outcome, and I feel very active in my mind saying, what could I do better? What thing could I fix? Or somebody comes back who has a great voice, and I say, what did I do right? How am I going to replicate that? I think I'm evolving and changing and trying things as much now as I did when I posted on my website, 20 some years ago, hey, I'd like to try this procedure. So for me, it's just very rewarding. But all voice that's not limited to this trend. I find voice fascinating. There's a lot yet to be discovered about the nerves working to run the vocal cords. There's a lot to be discovered about dealing with cancer on the vocal cords. How could we do better? So because it's an ongoing learning process, working with altering the pitch is still fascinating to me.
So as you think about how far things have come in the last, say, 20 years, where do you think this field's going to be 10 years from now, 50 years from now? What do you think's on the horizon?
Well, two things. One, of course, if we could, I think we will alter what we do for young people. One thing that the political will doesn't consider, let's say in conservative states, is that not doing something is doing something to the person. Making a person live in a body they don't want for 30 or 40 years is a huge price. So you need to be an economist and put that price onto what if you do something and it's wrong, and you need to weigh the two things equally. So I think we'll hopefully get through some of that and make some changes in what we do for young people, because we've clearly changed what we do for young people in the past 20 years. I see many more families coming with young individuals accepting the young person's choice and supporting it. And that seems wonderful. That's one thing that'll change. And then I spend a lot of my time teaching. I lecture. People come and watch this surgery. I think somebody who's 20 or 40 years younger than me is going to come up with some new idea, and it's going to be better than what I've done. And then more people will adopt that.
That's exciting. So kind of always growing, always changing.
Yeah, always growing, always changing, pass the baton. Look, I guess I can mention I'm a Democrat. Biden just finally passed the baton. I hope I'm not that resistant to passing the baton to the next person who wants to do something. But he did do it, so I'm open for some young person to do a better surgery than I'm doing.
You can hand over the scalpel.
Yeah. I'd love to see other people trying to do something better.
That's really cool. We didn't talk about this at all, but I would feel remiss if I didn't bring it up, which is, do you ever do pitch lowering surgery?
I do. I think I don't do much of it, so I don't have as much experience. I think there's a couple reasons for that. One is that testosterone is such a potent changer of the voice, so surgery isn't needed as much. Secondly, I don't think someone's come up with a great way to change a female size voice box into a male size. So the main surgery for a trans man to get a lower pitch is to loosen the vocal cords. But in a tiny space, if you loosen them, sometimes you get a gain and sometimes you don't. Again, maybe it's the next generation. We need a way to take this trans man's voice box, drop it down in the neck, expand it forward, make the vocal cords longer and heavier. And I don't think we've developed that yet. I think about crazy ideas. I talked with one patient. We talked about, wouldn't it be interesting to inject like testosterone maybe directly in the vocal cord? Could you get a better effect? I don't know. Could you change locally the anatomy by that way? That's probably not the right idea, but someone's going to say, okay, sound and physics, we need a trans man to have a big low larynx and a big throat. How are we going to accomplish that? Can we do it with surgery? Right now, we can kind of change one thing, tension, and that doesn't really do it for everyone.
Well, I mean, I so appreciate you talking to me about this today, because I know there can be such sort of a invisible barrier for a lot of people to access information about surgery and from physicians directly. And so the fact that you're sharing this with people so freely is just fantastic.
Yeah, I think, I guess where a push could be is people who are pushing insurance companies to work with patients. I think maybe we should keep pushing there as a society, as individuals, in dealing with these issues. the same as any other medical issue that we deal with. That's where I think we should put our efforts.
Well, gosh, talking about this stuff makes it all sound so interesting. Like it's taking me back to my science fair project in, I think it would have been grade 5, was based on something I saw at was it the Exploratorium? Is that a real place in San Francisco or something?
It could be.
But it was I got a duck call and attached tubing of various sizes to it to simulate vowel sounds by kind of doing a rough modeling of the vocal tract. So you'd blow into the duck call and it would be like ooh, ooh, ah, ah, as you switch the tubing out. And I'm now thinking about that and going, God, I could have studied this in another life.
I think the same thing. I actually think the same thing. And people ask me, like you did at the beginning, how did I get here? And I said, well, I had this nice toy, and I started the story after I was a doctor. Mm-hmm. But I could look back to the science fair. My project was aerodynamics, and aerodynamics is how sound is created. So I've actually kind of been working on the same thing my whole life, from my science fair project all the way up till now.
That's very cool. I mean, I can see you have a very curious approach to all of this stuff, thinking about new ways to do things.
Yeah.
And clearly making sure you're doing it well. Okay. Those are all of my questions. You've answered them fantastically, so I really appreciate all of this time. Thanks so much for talking to me today. If people want to find out more about you or what you do, where can they go?
Well, I still have the website up, voicedoctor.net. I suppose that's the easiest way in the online world, is to get there and see what's there. It's a way to contact me if you have some specific interest. But
great.
Yeah.
Well, thank you so much.
It's been fun chatting. Thanks.
I hope you enjoy the rest of your day.
Thank you, Jess.